Can I come in?
Yes,
Hi, my name is Susie. I'll be your nurse practitioner today. What's your name?
I'm Cameron.
Hi,
Okay.
Cameron. What's your birthday?
11/5/1993.
All right, well, nice to meet you, Cameron. What are we doing today for you?
I believe just a general physical examination.
And then, do you know what city we're in?
Yes, we're in El Cajon, California.
All right, perfect. So, as I'm walking into the room, I'm assessing a general survey on my patient. He seems comfortable, appropriate posture. He's dressed appropriately for the weather and situation. He's alert oriented times four to time, situation, himself, and what we're doing. I don't notice any distress that's apparent to me on my first look at my patient. When he shook my hand, I feel his hand is dry, his skin is pink. I don't notice any obvious wounds or anything that's concerning at this moment. Um, Before entering the room, my nurse obtained a vital sign set for me that has blood pressure, heart rate, height, weight, everything within the fine limits for this patient. I'm also having a clear conversation where he's having clear speech, organized ideas, nothing out of the normal that I'm concerned for. He's making appropriate eye contact with me. He's calm and we're having a good report. Next thing is I'm going to move on to the skin. I'm looking at my patient's skin. His face and torso appears to be appropriate for his ethnicity. Is pink, warm, and dry. There's no open wounds or any active bleeding. If there were wounds or active bleeding, I will move on to further evaluate with the ABCDE method. The texture is smooth, is appropriate for my patient's age and ethnicity. I'm also assessing for tenting by pinching a little bit, and there is no tenting, so that means my patient's hydration status is appropriate. Um, like I said, his vital signs showed up temperature 98.6, so it's appropriate for this patient. Now, like I said, no bruising, no cuts, no wounds, lacerations, anything like that. Moving on to the head and face of my patient. I'm inspecting, that's my first step. My patient's head is symmetrical. There's no deformities, there's no masses, no contusions, no abrasions, no crepitus, no tenderness or swelling anywhere. Is there any tenderness or swelling?
No.
Or pain?
No.
All right, perfect. So we're palpating at this point. My patient's head, there's no boggy spots, no hematomas, no open wounds, lacerations. I'm also assessing as I go between my patient's hair, making sure there's like a partition here, looking, there's no scabs, no uh, like lesions, no bugs there crawling, your head has not been itchy at all.
No.
So perfect. My patient's hair is evenly distributed throughout, and it is also evenly distributed to eyebrows and eyelash section. Patient seems to have shaved this morning, so no facial hair at this time, but everything is within the fine limits for my patient, including his head and face. We're going to palpate my patient's sinuses. We're looking at the frontal here, any tenderness.
No.
And then we are going to the maxillary. Any tenderness?
No.
Perfect. So, like I said, while I'm inspecting my patient's face, is symmetrical, skin's pink, warm, and dry, no masses, contusions, abrasions, crepitus, tenderness, anything like that, and no tenderness as well. So now we're gonna look at my patient's mouth, and I'm gonna have you say ah for me big when I tell you to, but first we are just going to actually, first thing, can you just open without making a noise and close, open, close? So I'm assessing for temporomandibular joint. Is there any pain when you're doing that?
No.
All right, so no pain, no clicking. So his TMJ is appropriate. It has full range of motion. So as I'm inspecting the nose, I'm gonna have patient look up and in the nostril with my light, and I'm looking at his nasal cavity. It's patent. I don't see any polyps, no bleeding, no irritation. I'm looking at my patient's turbinates. It's moist, pink, reddish in color, which is appropriate. Any pain when I'm palpating your nose?
No.
No deviation of the septum as well. So that is great. Now we're gonna move on to feeling sharp or dull for cranial nerves. Close your eyes.
Sharp. Sharp. Dull. 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 Sharp. Sharp.
Okay, perfect. So this tells me that his cranial nerve 5 is intact. Now I'm gonna have you cover your right nostril, and can you smell? And okay, the other side. And can you smell? You could smell. Okay, so that means my cranial nerve 1 is intact. Now I'm gonna have you do a few movements with your face. Can you raise your eyebrows? Can you squeeze your eyebrows really tight for me? Tight, tight, tight. Perfect. Big, big smile. Show me your teeth. Puff your cheeks. Perfect. So this tells me his cranial nerve 7 is intact. Now we're gonna move to the eyes. We're gonna do an external inspection. There's no nodules, there's no drainage, no swelling, discoloration. Like I said earlier, the eyelids are appropriate. Can you close them? Open. Perfect. Opening and closing in appropriate movement. Eyebrows, eyelashes evenly distributed throughout. I'm looking at my patient's sclera. Can you look up and down, just the eyes, not the face? Up and down, and then left and right. So his sclera is white and not non-icteric, non-injected. There's no drainage, no bleeding, no lesions, or obvious like bruising around. Now I'm gonna pull down on your eyelid. Can you look up? I'm looking at my patient conjunctiva. There's no redness, no discharge or anything. Are your eyes feeling sticky at all? No burning sensation at all either. Okay, perfect. So now I'm gonna have you look at my eyes, and I'm gonna shine a light into your eyes. And you look at me. Okay. Okay, so my patient's pupils are 3 to 2 millimeters, and then they are equal, round, reactive to light and accommodation, which is what we're expecting. Now we're going to assess my patient's eye with the ophthalmoscope. And I'm going to have you look over my shoulder as I'm doing this. Tell me when you're ready. Okay, you look over my shoulder, okay? So as I'm looking into my patient's eyes, I see my red reflex going in. I can see a yellow optic disc. I can visualize in both eyes. The margins are sharp. There is no hemorrhage. Vessels are visible. The retina is intact. There's no patches. The cup to disc ratio is 1 to 3. Let me see one more time. One more time. Can you look at me directly this time? My light? Okay, is it blinding? Sorry. Okay, so the macula is seen when my patient is looking at my light. Okay, now I'm gonna have you, sorry.
It's okay.
Look at my finger, just with your eyes, not the full head, okay? And just follow. We're gonna go up and down, and this way, diagonal. So when we're having this patient move the eyes in this direction, we're looking at the 6 cardinal gazes, and this tells us that the patient's, okay, one more thing. So there's a movement that is fluid. I don't notice any shaking when he's doing that, so that's no nystagmus. When he's following my finger, this tells me the cranial nerve 3, 4, and 6 are intact, which is great for this. Now I'm going to do a visual acuity on my patient, and for this we're going to position ourselves 14 inches away from the patient, and then I will have you cover your right eye and then read the lowest one that you can.
LTFPH.
Okay, we're going to do the same with the other eye.
LTFPH.
Okay, now let's do it with both eyes.
I'll do it backwards. HPFTL.
Okay, so this is my patient's vision since 2020 bilaterally. And then this tells me the cranial nerve 2 is intact for this patient. Now we move on to my patient's ear. Externally, they seem to be appropriate. They're both present. They're both fully attached to my patient's ears. There's no obvious drainage, leaking, no swelling, bruising, or hematomas. I don't notice any masses or anything concerning visually. Now I am going to palpate behind your ear. This is my mastoid process. And is there any tenderness?
No.
So there's no tenderness, no swelling or masses palpated here. Now we're going to look again at my patient's ears with my ophthalmoscope, my otoscope, I'm sorry. And we're going to pull the pinna open backward to get access to my patient's ear canal. Find it. Okay, so there is very minimal ear wax on this ear, but we're able to see the tympanic membrane is grayish, pinkish in color, grayish, whitish, is not injected, there's no bleeding, no, nothing concerning. Again, moving on this one. This one does have a little bit more of earwax, but I'm able to see my tympanic membrane. It's grayish, whitish in color, non-injected, there's no bleeding. I'm able to see my internal, my structure of my tympanic membrane and my cone of light, so that's all appropriate. Now we're gonna do a whisper test to test for my patient's cranial nerve 8. I'll have you cover one of the ears. Can you cover your left ear and then repeat my number?
24.
Okay. Cover the other ear.
65.
Okay, perfect. So this tells me my patient's cranial nerve 8 is intact. We're moving on to the mouth. Like I said earlier, externally appropriate. Both lips are moist, pink. There's no cracks. Can I have a big smile on my and open? His teeth are present and appropriate for his age. There's no teeth missing or any obvious like swelling or bleeding gums. So now I'm gonna have you stick out your tongue for me. Can you stick your tongue out all the way and then just lift it up and down, side to side? Perfect. All right, so this tells me my patient's tongue is symmetrical, is attached. I'm gonna look at my patient's frenulum. It's there, it's not bleeding. I'm gonna have my patient stick its tongue out, looking with my light. My patient's uvula is midline. His tonsils are small to the bilateral sides, no pustules, no bleeding, nor erythema. I'm gonna grade his tonsils at grade 1. They're non-touching, and I don't see any swelling or abnormalities there. The buccal mucosa is moist, pink, tongue is not cracked, which is also indicative of his hydration status and is appropriate for this patient. Last thing, I want to have you shrug your shoulders, push against me. Perfect. So as I'm doing all this, we see the other thing that I would do for this patient, we would push with the tongue depressor to trigger the gag reflex, but this patient is awake, alert, oriented, talking to me, so I'm not going to do that to him. We can assume that the gag reflex is present for this patient. So this will mean his cranial nerve 9, 10, 11, and 12 is intact, and we can move on to the neck. We assess visually, midline, no distension, no bruising, no masses or abnormalities that I can initially see. We move to palpating. I'll have you stand up and turn around. We're gonna palpate from the back, and we feel my patient's neck and find the thyroid. Now have you look right, and then left, and then down, up, like normal again. Swallow. Okay, so there's no tenderness at all anywhere when I'm touching?
No.
Perfect. You can sit down again. So when I'm assessing to my patient's thyroid, he's able to swallow, he's able to move around, there's no pain, there's no nodules or masses or no goiter noted or felt. I can look at my patient's neck and I'm assessing for jugular vein distension. My patient's jugular vein is appropriate, non-distended that I can see, and I'm going to auscultate my carotid arteries looking for bruit. Can you have take when I place my stethoscope on your neck, we'll take a deep breath and hold it in, okay?
Okay.
Deep breath in. Hold it. Okay, so no bruit noted on my patient. And now we're going to move on to palpate my patient's lymph nodes. We're gonna start with the occipital. Then we're gonna go preauricular, postauricular, submandibular, submental, and supraclavicular. So all my lymph nodes are soft, they're non-tender, there's no pain anywhere where I've touched. Okay. No swelling or deformities noted, which is good. Now we're gonna listen to my anterior thorax. Take a deep breath in every time you feel my stethoscope touch your chest, and out. So all the sites I assessed, lung sounds are clear, equal bilaterally. There's no adventitious lung sounds on this one. I am going to touch around and I'm going to have you say 99.
99, 99, 99, 99, 99, 99.
Okay, so no tactile fremitus is noted on this patient. We are going to find and palpate the point of maximum impact for this patient's heart. Perfect. And now we're going to auscultate.
99?
Just one. Sorry. Perfect. So S1 and S2's heart sounds are clear. They're normal. I don't hear any murmurs or anything different than the normal for this patient. Now we're going to auscultate the different sites for the heart from this patient, both using my diaphragm and my veil of my stethoscope. You can breathe normal, okay? I'm just going to be listening to your heart sounds. It's going to be in the aortic site. The pulmonic. Herbs point. Tricuspid valve. And my mitral. Okay, so as I'm listening, I'm able to hear everything appropriate. There's no murmurs. S1, S2 assessed. And again, looking at my patient's chest, there's no discoloration of deformities. Clavicle is appropriate. There's no tenderness. Ribs are all present and appropriate. No tenderness either.
Nope.
Okay, so all great with my patient's chest. When he's breathing, I see, take a deep breath for me, and out. Symmetrical rise and fall of the chest. There's no accessory muscle use. There's no indentation in the ribs, no increased work of breathing. So that's appropriate. Can you sit facing that way on the edge of the bed? If I can. And just like right here. So we're going to do the same thing, but we're going to do back. I'm going to move and listen to different parts of your back, and I'll have you take a deep breath in and out, okay? Deep breath in. One. And okay. And then as I am examining, I'm gonna have you say 99.
99, 99, 99, 99, 99, 99.
I'm gonna do it with my hand now, and you say 99.
99, 99, 99, 99, 99.
Perfect. So while I'm doing here, I'm assessing for tactile fremitus. There's no tactile fremitus noted. Sound muffled when I'm auscultating, and he's saying 99. So this is appropriate for this patient. That's what we are expecting. So now we're gonna percuss. The tone is resonant in all fields, and that is appropriate as well. Is there any pain when I'm feeling down here?
No.
We are assessing for the costovertebral tenderness, and we are following this ankle bilaterally, feeling around the kidney area. This will be indicative of a kidney infection. Is there any pain when I'm touching there?
No.
Perfect. Again, overall, pink, warm, dry, deep breath in, appropriate, no retractions on the back gravity there, so it's perfect. Scapula is symmetrical, there's no tenderness back here, so that is good. I'll have you stand up again, and then if you can turn, yeah, just lay down this way with the head, because we're going to be looking at your belly now. This way a little more.
To that?
Yeah, perfect. So now we're inspecting my patient's abdomen. So while we have our patient down here again, we're going to assess our jugular vein distension again. This time we're going to measure it. We have a measuring tape. Can I see? And it is about 2 centimeters as expected. As I'm feeling, my patient's abdomen is flat. There's no distension. The color is appropriate. There's some abdominal hair that's appropriate for a male this age. There's no obvious deformities or discolorations. There's no waves or pulsation that will be indicative of any acute processes going. Now we're going to auscultate the 4 quadrants of my patient's abdomen and the aortic and renal arteries. You don't have to do anything. I'm just listening to your belly. Okay, so as I'm listening, there's no worry to my patient's abdomen area, and there is bowel sounds present, normal active. I'm gonna percuss in my patient's belly. Okay, so there is tympany in all quadrants with dullness over the liver, and we're going to palpate my patient's abdomen. There's no masses or distension. There's no tenderness. We're gonna do a deep palpation. Tell me if it's tender when I'm touching.
If what?
Tenderness. Perfect. Now we're looking for patient's liver. We're gonna place our hand behind the patient. Gonna lift the liver up and feel. It's about 7 centimeters in span and about 1 under the rib. Perfect. Okay, so then we're gonna check for the ellipsoid sign. Can you lift your leg for me and then push against my hand? Is there any tenderness?
No.
So no tenderness indicative of potentially not appendicitis. I'm gonna press on your right lower quadrant. And is there any pain when I let go or when I press?
No.
Okay, perfect. So no rebound tenderness as well. I'll have you sit up for me. We are assessing a quick vascular assessment on my patient. We're moving on to this feeling my patient's gap refill. It is appropriate. And then less than 3 seconds bilaterally. Pulses. We're moving on to the radial. Brachial pulse 2. And then radial. Brachial pulse 2. Carotid. +2. Now we're moving on to our dorsalis pedis, +2, and then posterior tibial is +2. As we're doing this, we're looking for edema, any swelling or missing hair on the legs, which is not present in this patient. There's no edema, no pitting edema, no shining, no exudate, anything from the legs. Patient skin warm, dry throughout, so that is good. And then, can you tell me if you feel dull or sharp? Close your eyes.
Sharp, dull, sharp, dull.
Right, perfect. So appropriate for this as well. Now I'll have you stand up again one more time, and I'll have you walk that way and then back to me. My patient's walking steady gait, appropriate. Can you face me this way? So that is a good neurological assessment. There's no wobbling. He's walking independently. Can you stand straight, arms sideways, close your eyes? This is my Romberg's test. If my patient was wobbly and moving, I will be concerned, but my patient's able to stay steady, and this is a negative Romberg test. So you can open your eyes for me. Now we're gonna test my patient. You can sit down. Deep tendon reflexes. We are testing for the brachial radial. Let me see your arm. You can rest it right here. Palpate the tendon. And a quick brisk hit to the tendon. And then other side. Perfect. And then can you flex your muscle for me? Let's find the tendon here. We're going to, you can relax. Now that we have the tendon identified, we're gonna do a brisk tap. And then find the other one. Can you flex for me just a little? Relax. Now we're going, this was my brachial, my bicep. Now we're gonna move on to the tricep. It's gonna be behind the elbow, follow right above it. I'll have my patient rest his hand, relax, relax for me. Once we find the tendon back here, we do a quick tap. And great. Other side. My patient rest his arm on me. Sit up. Perfect. Relax, relax, relax. Fully relaxed. Arm. This is my triceps, deep tendon. A quick brisk tap. Okay, great. Now we are going to do the patellar. And then for this one, we're gonna do a little below and outward of the knee. Find that spot right here and do a brisk quick tap. And other side. Yeah. Okay, so +2 to all the sites that we tested for this assessment, which is appropriate and what we expected. Last thing, we're going musculoskeletal for my patient, and I'll have you stand up and then bend down, touch your toes. Spine is symmetrical, scapula is appropriate, there's no deviation, no obvious signs of scoliosis. I'll have you stand up again, and then I'll have you shrug your shoulders, do a little roll, and then forward and down, and bend your arm like this, down, rest, okay, and then again up and down, and reach back behind your back. Perfect. And I'll have you sit down, bend your knees for me. Can you bend your knees up, down, ankles, ankle roll? Perfect. So range of motion intact to all extremities. Can you squeeze my hands and push down? So push down and up against me. Perfect. Foot, push up against my hand. That one. Okay, give me your feet and down like a pedal and up against me. Perfect. So strong. Now we're gonna do the Phelan test. Hands, wrists against each other. 60 seconds. 60 seconds have passed for this test. Release. Any pain?
Nope.
All right, so this is a negative Phelan test, which is indicative that my patient is not reproducing the characteristic symptoms of carpal tunnel syndrome, and that is an appropriate finding. All right, so this concludes our physical head-to-toe assessment. Thank you for your help today.